Hello and welcome to the EduTalk series hosted by Biotone EduPartner School Program, and massage industry experts. With the continued interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Today's expert is Dr. Jared Cooper, aka Dr. C. He's a physical therapist, a massage therapy instructor, and a CE provider for over 25 years. He's the founder of Moment Physical Therapy and is the former clinical instructor at Rutgers, Seton Hall, and Western Carolina University. Most recently, he's been a presenter at the 2024 AMTA National Convention. Let's listen and learn as Jared, Dr. C, presents myofascial release clinical strategies. It's part 2 of his 2-part EduTalk series. He'll reveal what is the best way to address myofascial restrictions and explain how to most effectively influence the myofascia to restore length and flexibility. He'll discuss how long and how intense does your technique need to be, and will share science-based clinical strategies for addressing soft tissue dysfunction and using myofascial release. Jared's part 1 of his EduTalk is the new science of myofascial release, and he presented that on January 7th. The recording is posted to the EduTalk archive library on biotone.com under the EduTalk tab. And I know we've got a lot to get to. Jared, thank you so much for joining us again. Before I turn it over to you, I'd just like to mention everyone, thank you for having your sound off and video off, and feel free to chat questions, which Jared will answer at the end. With that, thank you again. I'm going to exit the screen. I'll be back at the end of your presentation. It's all yours.
Awesome. Thanks, Donnell. Thanks, Biotone, for having me on. Super excited. A couple of weeks ago, we did part 1. It went amazingly well. I highly recommend, if you missed it, that you check out the recording. So first thing I want to know is, what is your current favorite technique? That can be trigger point, deep tissue, myofascial. It can be a specific technique that you use in your practice right now. Maybe it's cupping, instrument-assisted work, stretching, something that you love to go to, something you love doing. So the way to kind of give that in is, if you look at the bottom of your screen, you'll find that little chat feature. Click on that little chat button, and that little chat thing will show up on the side of your screen there. And I want you to type into the chat what your favorite technique is. I'm going to put in myofascial release. Y'all should be seeing that come up right now, even though I spelled it wrong. So put in your favorite thing to do. Aaron loves deep tissue. Wendy, tuning forks. All right, you got to let me know more about that. I don't know much about using tuning forks in bodywork. That's awesome. Body-mind connection, myofascial release from Patrick. What else you guys got? What do you love to do in your practice? Something that is just your go-to, and something is stuck, something's not moving. It's the tool that you pull out. Go ahead and put that in the chat now as I pull up the presentation. Meryl seems to do any deep tissue work on most people. Some version of that, true. Again, Sebastian, myofascial and stretching from Deirdre. Awesome. RV put Grayson. I think you meant Graston? Did you mean Grasson or Grayson? Is Grayson a technique? Feldenkrais, Sebastian. Good on you for that. All right. Hopefully y'all can see my presentation. I'm going to full screen this. Okay, so you can keep those coming in the chat. I got my chat over here to the side. So this is basically myofascial release clinical strategies. And if you missed part 1, don't worry. I am going to do a quick review right now of part 1 in case you missed it. But before I do that, real quick, I am a native New Yorker. I got my bachelor's from Cornell University and my doctorate in physical therapy from USC. I opened the first holistic fitness studio in New York City where we did massage and acupuncture and all sorts of things all kind of blended together. And I ran a practice in Jersey for 10 years called Moment Physical Therapy, which we sold in 2020, right in the middle of COVID. And I moved to North Carolina to teach and live here and be in the mountains, which is awesome. And I was a clinical instructor for a bunch of cool places. I currently teach at the Center for Massage and Natural Health in Asheville, and I teach continuing education all over the country. I taught at the AMTA National Conference last year, and I run a small practice called Bodywork Dojo now where I treat clients, and I've been doing this for a long time. So that's who is talking to you right now. So a quick review of part one. In part one, we talked about this concept of like, we're trying to get at what is myofascial release? What is the science of myofascial release? And I introduced this concept to you of layers that essentially, whoops, hang on a second, technical issues here. Let me move this chat screen out of the way so I can see y'all. Basically, you've got this idea of layers. You have the skin, which is the superficial fascial layer, otherwise known as the dermal fascia. And then under that, you have the deep intramuscular fascia. And then in between those two, highlighted in red, over on the right-hand side of your screen, is something called the hyaluronic acid layer. And the hyaluronic acid layer contains a super slippery substance, hyaluronic acid, which basically prevents force transmission between the skin layer and the muscle. And we know this to be true because when you contract your muscles, your skin doesn't move. That would be a little bit weird. It does in your face, but nowhere else in your body. And likewise, if you push and pull on the skin, it doesn't actually affect the muscle. We know this to be true because there's been several studies, including this one, that basically looked at what were to happen if you were to push and pull on the skin to the muscle underneath. And as it turns out, nothing. If you push and pull on the skin in the upper back, the muscle layer underneath displaces like a millimeter or so, which is not much at all, which means that a lot of the techniques that you see where you're pushing and pulling on skin aren't really myofascial techniques. They'd be more accurately termed dermal fascial techniques. So what is myofascial? We had to go into the connective tissue to answer this, and we looked at the connective tissue. All connective tissue is composed of three things. It's composed of cells, which live in something called the matrix, and the matrix is composed of ground substances, which is like this honey goo, and you have fibers. The one that we're most concerned about is going to be collagen, which basically holds us together. And the cells not only live in the ground substance, but they influence the ground substance. And they also are responsible for remodeling the collagen. So there's this relationship between these two. And understanding this is going to help us to understand how to do myofascial release. Now, if you just take the cells and you put them in a petri dish and you put some collagen in the petri dish, instantaneously the cells go to work remodeling the collagen. So that's pretty cool. So you see on the left, a bunch of cells drop a bunch of collagen in there, and they start remodeling the collagen. So we know the cells are designed to remodel the collagen, but they don't know in which direction to remodel the collagen unless you tell them. So I showed you this image, and we saw that on the left-hand side was a normal medial collateral ligament, an inner knee ligament on a rat. Then they lesion the ligament, and 4 weeks later, without treatment, the middle picture you can see the rat ligament is an absolute mess. That's without treatment. But if you do a form of myofascial release onto the ligament, the picture on the right is what it looks like after 4 weeks with treatment. So we know that when you apply an input to tissue, you're telling that tissue to remodel in a particular way so long as you provide the right input. And the way this works is as you push and pull on tissue, the force that you're applying is translated down to the cells and it changes the behavior of the cells. And that's called mechanotransduction. You don't need to know that word, but what I do want you to take away from this particular slide as a review is that force is the language of cells. Fibroblasts speak force. They feel force, they sense force, and they change their shape and they remodel collagen in response to force. So we have to talk to the cells. That's the key. Then we talked about this idea of tissue either being stiff or short, and stiffness, stiff tissue, is really just thick honey. It's a property of the ground substance. And when you want to make something less stiff, all you got to do is just stir the honey. In other words, any technique will really make somebody feel looser because the feeling of being looser is just a property of the honey. It's not a property of the collagen. And so even when my 12-year-old gives me a shoulder massage, I feel better. Not like he's got some great skill in body work. It's just because rubbing something makes it feel better because you stir the honey and you increase the temperature. What we're more concerned about is tissue shortness. Tissue shortness, that's adhesions, things being stuck together, things not being able to elongate. Yeah, and that's what needs to be remodeled, and that's what myofascial release where it really, really, really shines, where we want to put our focus. And depending upon the kind of load you put into the tissue, that's what you're going to get. So if you load muscle, what do you get? Bigger muscle. We call it hypertrophy. If you load skin, what do you get? A callus. If you load bone, what do you get? More bone density. If you load fascia, you're going to get remodeling so long as it's the right kind of input. Okay, so that was the crash course on part one. And we actually finished part one with this question. How do you get the cells to remodel the myofascial tissue to create lasting change rather than temporary change? Because when you stir honey, you just massage something, right? What happens after a couple hours? The honey cools off and then it gets stiff again. And that's where you don't get lasting change. We want to remodel something, we have to know how to talk to the cells. And that's what today is all about. How do you do this? So in order to understand the new science of myofascial release and how you clinically apply it, we really have to go back to first principles. And by first principles, I mean understanding very basic physics. And in physics, there are only three kinds of actual forces that you can impart to anything, including human tissue. That is compression, squeezing something together, tension, pulling something apart, and shear force, which is sliding two surfaces on one another like this. Like an ice skate goes across an ice skating rink, that's shear force. We also sometimes refer to it as friction, which is the result of shear. Now you might say, well, what about bending something? Well, bending is actually a combination of compression and tension. When you bend, the bottom half goes on compression, the top half goes on tension. That's really a combination of those two forces. And rotation or torsion, twisting, is actually compression and tension. When you take a towel and you twist it, the reason the water comes out is you're compressing the towel down by applying tension to it. So fundamentally, there's only three forces: compression, tension, and shear. So if I ask, what is myofascial release? The answer needs to be some combination of these three forces. Like, what is it? Yeah? And so that's what we're going to look at right now. So imagine as though you just had tissue. It doesn't make a difference what kind of tissue. We'll just say we have tissue. And let's say it's muscle tissue. And we put a tissue restriction in the middle of our myofascial tissue here. Which one of these three forces, pushing down onto the restriction, sliding across the restriction, or pulling on both ends of the muscle? In the chat right now, put down which of these forces do you think is most influential to the cells in order to remodel the tissue. So take a moment, go into the chat, and I'll put my chat window up here to see what y'all are saying. Which of these forces do you think are the one that is going to generate the most amount of remodeling in the tissue by the cells? All right, so we got a few votes for tension. Gary says shear force. Michael says shear force. Chelsea, tension. Odd, no one's going for compression on this one. Oh, Patrick, good on you. Compression. Marty, tension. Aren't they working together? Deirdre, tension. Yep, okay. Keep that coming in while I go on here. Nice. All right, so what is it? How do we do this? Well, let's take a look. We're going to first look at tension, which is basically stretching something, right? So if I take my forearm and I go like this, my forearm flexors went on tension. So what are examples of this? What are brand names of putting tissue on tension? We got passive stretching, active isolated stretching, and a whole host of other things that have the word stretch in it or put tension on the tissue. All right, so what happens when you do that? So I'm going to flip this into a really simple model. Imagine these are interlocked rings of rubber, like collagen rubber, like rubber tubes. So you got interlocked rings. And that middle ring, which represented our tissue restriction, is stiffer than the rings around it. What happens when you pull on the two ends of the muscle? Which of these rings is going to stretch? The tissue restriction or the rings that are less stiff? Which one is actually going to stretch? And I think the answer is relatively obvious. Strain follows the path of least resistance. So if you have a restriction in a muscle or a myofascial complex, somewhere in the myofascia, and you just stretch it, thinking that you are influencing that restriction, that's not likely what's happening, because what is going to stretch is the tissue above and below the restriction that is already flexible. So that's the problem with just using myofascial stretching or stretching as a modality for clearing myofascial restrictions. Strain follows the path of least resistance. So it's good for improving the length and extensibility of the whole muscle, but it doesn't target myofascial restrictions. Okay, what about, for those of you that said compression? What if we just push on the restriction? What would be an example of doing that? Well, trigger point release. When you do trigger point release, you are applying compression right on the spot. Static compressions, like you do in Swedish, you're going to that right on the spot. There's other modalities that kind of focus on applying compression. What happens if you apply compression to a tissue restriction? Well, again, let's go back to our little model of rings here. And what do you get? You just got a flat middle ring. What that does not do is it doesn't tell any of the cells that are in that area that you need the collagen to be remodeled in a lengthened position. All it does is tell them that they need to remodel in that spot, but it does not increase the length of that adhesion or that restriction. So that alone won't do it. It's good for targeting trigger points, but compression alone will not tell the cells to make longer tissue. That's the problem with compression alone. What about shear force? Well, when do we do shear? Well, when you do Swedish, a lot of Swedish is gliding across the surface. Lomi Lomi, Graston technique or gua sha is using a lot of shear, right? So that's going across the tissue. So what happens with shear force? Well, shear force essentially glides over the restriction, which means it's really, really good for increasing the tissue temperature. It definitely stirs the honey. If you don't use a lot of lotion, like with gua sha, if you do it relatively dry, you definitely get a lot of blood flow. So it's good for reducing stiffness, increasing heat, but again, it alone does not tell the cells that that adhesion or that restriction needs to be longer because the tool that you're using, whether it's your hand or anything else, is passing over the restriction. Okay, so what do? What if we start combining forces together? So what if we add tension and compression together? So here's our restriction. We put it on tension, and then we add compression. Now what happens? Now, like if you had a rubber band between your fingers and you pull on the rubber band and then you apply another force in the middle of the rubber band, the compression focuses the tension to a desired point along the fascial line. And what that does is it drives the stretch into the tissue where the restriction is located. Now what were to happen if you add shear force to that? So once we add shear force, not only do we get focal stretching at that location, we can then direct that stretch towards the origin or the insertion or across the fibers at that location. And what that does is it tells the fibroblasts, or more specifically in the fascia, the fasciocytes, exactly in which direction they need to remodel the collagen to resist the force that you are applying there. Because ultimately, remodeling is an adaptation to deal with strain. So tension of the tissue plus compression plus direction or shear is what talks to the cells the most. And now the cells go, oh, now I know in which direction to remodel this tissue. So myofascial release, in sort of like the new science perspective, is really a three-dimensional technique that combines the three forces of physics that we can apply to tissue: tension, compression, and shear. And all three of those forces combined together are the most amount of input and the most accurate input that you can give to the cells to tell the cells how to remodel. All right, so if you followed all that, go ahead and put that in the chat. Just say gotcha right in the chat. Tell me you are following this story so far. Put gotcha in the chat. All right, so here's the analogy, the ball of yarn analogy. I want you to imagine that, and by the way, I give this analogy to my clients and my patients when they come in because it helps them to understand what the hell we're doing. It's the ball of yarn analogy. So when we're babies, all of our fascia is like in this beautiful, oh, Marty, Wendy, thanks for the gotcha there. I love that. You get this beautiful connective tissue fascia when you're a baby. Everything, all of your collagen is all lined up nice and beautiful. And then, of course, what happens? Life happens essentially, right? You get injured, you get strain, and that leads to things like stiffness, adhesion, scar tissue contractures, trigger points, decreased gliding. Essentially, it's like you tangled the ball of yarn and you dropped a bunch of glue in it. And so now you can't untangle it. So obviously, step one is break up the glue. That's actually what the word release is referring to. It's referring to something letting go of something else. That's what the word means, to release something, to let go. So when you've got that tangled ball of yarn, if you remember that picture of the medial collateral ligament on the rat that I showed you, and that absolute mess that it looked like when it was all adhesed and disorganized, the first step is to break that glue up. That's the release. And the second step, of course, is to remodel the yarn, to pull it apart. Well, here's the thing about myofascial release. When it's done using all three forces, you get all of it at once. It's a one-stop shop. The compression breaks up the glue, and the tension and the shear remodel the yarn. And this is the only modality that does that. Deep tissue won't do it because it's not on stretch. Simply trigger point won't do it because it's not on stretch. Stretching won't do it because there's no compression. So that's the beauty and the power of myofascial release, is you're getting everything that you need all at once by combining forces. That's pretty cool. So let's ask the question, which myofascial tissue would benefit from myofascial release? Like, how do you know when you're assessing somebody what it is that needs this work? Okay, so we're going to do a little experiment, because the very first thing I want you to understand about myofascial release is there is a group of people that do not need myofascial release. Or more accurately, there is a set of tissues that don't need it, and that is hypermobile tissue. If you have somebody who has hypermobility syndrome, like Ehlers-Danlos, or they are hypermobile in a region, like they dislocated their shoulder at one point in time, and now their subscapularis or their infraspinatus is hypermobile, that tissue does not need length. That doesn't mean you can't work on it. It just means you shouldn't work on it in a maximally stretched position in an effort to make it longer if it's already too long. So we're all going to do a test, and you're going to put the result of the test in the chat. So here's what we do. There's a score called the Baton score, and this score is a test to see how mobile you are genetically. And some people, like the kids in school that were double jointed, are all the way on the right-hand side of the curve you see. And some people that are really stiff are all the way on the left-hand side. There's a series of flexibility tests you can do with your clients to see whether or not they fall on the hypermobile or the hypomobile side. Meaning, do they need more length or do they need more stability, which is what you need to do for folks that are hypermobile. So it's a simple test. Everybody take your hand like this, okay? Keep your wrist straight, grab your pinky, and bend your pinky backwards, keeping it straight. And then look at it and decide, is it anywhere between 0 and 45 degrees, which is basically less than halfway? Is it 45 degrees to 90 degrees, which is more than halfway, like the picture that you see on your screen right now? Or can you bend your pinky back more than 90 degrees? So look at it and put it in the chat. I'll do mine right here. I'm guessing I look like I'm about 30 degrees. I'm not even halfway. So I'm going to put 30 degrees in the chat. I am definitely not hypermobile. If anything, I probably go towards the hypomobile side. Put that in there. Boom. 30 degrees for me. Elizabeth, you're hypomobile. Wendy, you're mobile. By the way, being mobile is perfect. You don't want to be hypomobile and you don't want to be hypermobile, basically. Meryl, just about 90 degrees. Donnell, you're at 40. All right. All right. You're with me on the hypomobile side. Deirdre, 90. Yep. Okay. Cool. Aaron, you're at 90-ish. Yeah. So some of y'all are pretty mobile and some of y'all are less mobile. Move that over there. Okay. Why does this happen? I mean, like, certainly those of you that said you were mobile, you're not walking around stretching your pinky. So how the hell did your pinky get mobile? The answer is genetics. Your flexibility depends on a lot of things, and the first thing it depends on is the percentage of your collagen type. There's actually 11 different types of collagen, not one, 11, which that's on the screen right now. And depending upon the proportion of collagen you have in your connective tissue will determine whether you bias towards hyper or hypomobile. The second thing is the ratio of collagen to elastin. And the third is the depth of your bony sockets. Some people have really deep sockets, so it kind of blocks their ability to move, and other tissue properties. Now, global hypermobility is not a contraindication to myofascial release, but proceed with caution. If you take somebody who's hypermobile and you do a bunch of myofascial stuff on them and you make them more hypermobile, you actually increase the risk of joint injury over time, because joints need to be mobile, but they also need to be stable. All right, so keeping that in mind about myofascial release, and you can use this little pinky test with your clients. Take that one home with you and use it tomorrow. All right, so which muscles need myofascial release? So if the concept is to make muscles or myofascial tissue longer, then which muscles do you target? And that brings me to the analogy of the guitar and the question, what do you do before you play a guitar? And the answer is obvious. You tune the guitar. You don't just go around loosening every string. You loosen the tight strings and you tighten the loose strings. You could say, in a way, that you're restoring the guitar to homeostasis. That making something in tune, if you will, in the metaphor of the guitar, is restoring the guitar to homeostasis. Well, the human myofascial web is like strings on a guitar, but instead of 6 strings, you have 600 myofascial strings. And those strings need to be tuned. I am not a proponent of the concept of people buying myofascial release as a service and then the therapist just releasing everything. It's kind of like if somebody bought the 10 series back in the Rolfing days, and the Rolfer is going to work one region at a time, making everything more flexible or more mobile, however you want to put it. Because like strings on a guitar, not every tissue needs to be longer. A simple example of this is, let's say you had a client with forward shoulder posture. You could say, oh, well, they need more length in the front. True. But what about the back? What about the periscapular region, like the rhomboids in the middle trapezius? Does that need more length? No. It's already stretched out by the malposition of their scapula. So myofascial release is about, first and foremost, identifying who's appropriate and inappropriate. That's what we did with the pinky. And second of all, identifying which tissue in the connective chain is actually tight, like a string on a guitar that needs to be loosened, and which tissue is already loosened and actually needs to be tightened. And it's the tuning of the guitar that makes myofascial release so effective when used in the context of trying to make somebody feel better. If you just release everything under the sun, what will happen is the already stretched stuff will get more stretched, the not stretched stuff will get more stretched, and the imbalance will remain the same because the relative tightness hasn't changed. All right, so I'm going to pause just for 1 second and give you a second if you want to put a question in the chat about anything that we talked about so far. I got a comment here. Sebastian says, stability always precedes mobility. It is so important to understand that stability is a huge component of function. Absolutely true. All right. Take a moment if you need to write your question in the chat. We'll get to those questions at the end of the talk. So here is my little drawing of how to think about this. The first thing you want to do is assess the system. So if you look at the iliopsoas, TFL, glute max, I just put a bunch of muscles there on the bottom, and you assessed how long are they, how long is somebody's muscle, how far do they go, and that's a range anywhere from short to long, I missed a short there under iliopsoas, sorry about that, from short to long, and you assess them and you find out that some stuff like the TFL, the iliopsoas, and the hamstring is too short, and other stuff might be too long. And what we want is homeostasis. So what we want is to move the stuff that's too short towards the center, and we want to take the stuff that's too long, and we actually want to move it towards the side of being stronger and a little bit stiffer. That sounds counterintuitive because we think we want everything to be flexible. No, we want everything to have the right amount of flexibility, not just global hypermobility, and we definitely don't want imbalances. This is what we want. We want to go from here to here, from here to here. We want to move things towards the middle, towards homeostasis. And then we can bias it a little one way or the other. If you're working with a gymnast, of course, they need more general flexibility than if you're working with somebody else, but that's the general idea. Oh, what is the deep six? The deep six rotators of the hip. So the piriformis, obturator superior inferior, no, gemellus superior inferior, and obturator internus and externus. That's what the deep six rotators are. Thanks for that question, Merle. So we think, what is the function of a symptom? Like, why do people have symptoms in the first place? It's simple. Symptoms warn us that something is out of balance. Basically, a symptom is just a check engine light. It's either there to tell you you're out of balance or something is throwing you out of balance. That's what it's there for. A symptom is there to tell you you are falling out of homeostasis. And I don't just mean pain. I mean all symptoms. Coughing, sneezing, rashes, fatigue, all that stuff, runny nose, all of those symptoms. They're basically just telling you that something is out of homeostasis. But oddly enough, clients come in and they're like, what do they complain about? Their symptoms. They want you to get rid of the symptoms. But that's not the problem. The symptoms aren't the problem. Of course, what's the problem? The problem is that something is causing a lack of homeostasis, meaning to eliminate the symptom, we have to balance the system. That is the modus operandi. And that requires assessment of the myofascial system before applying myofascial release. And you only apply myofascial release to tissue that tests myofascially restricted, not necessarily any tissue that's in pain. Because some tissue's in pain because it's too mobile and it's constantly on stretch. So we only apply myofascial release to stuff that is tight. Okay, this is true for the spine too. So this is called the wire hanger problem. If you think about the spine is like a giant flexible wire hanger. So when you bend over, right, to pick something up, because it's a giant wire hanger, what happens is the spine is going to move from wherever the spine is mobile. So if you think about this, everybody go like this with your hands, like you're holding a wire hanger, and bend the wire hanger down and up and 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 down and up, like somebody's bending over from one particular mobile spot on their spine. Where does the wire hanger break? In your hands or in the middle? I mean, it's obvious. The wire hanger breaks in the middle, in the part that's already moving. And the rule is the part that moves most is the part that wears out first. So even in the treatment of the spine, balancing flexibility, mobility with stability, and only treating regions of the spine that are restricted is part of the key. The idea is not to do myofascial release up the entire spine. It's to have the person bend over, find the region of the spine that's not moving, like the part of the wire hanger that you're grabbing that's not moving, and address the restriction in that segment. That's how specific we can get with myofascial release. So how do you find specific myofascial restrictions in tissue? Because if I'm telling you you should only treat the stuff that's restricted, how do you find that stuff? So I'm going to show you a technique. I'm going to show you a video in a second. And this is a video of me demonstrating something called motion palpation. And motion palpation is different than static palpation. In static palpation, the person's not moving and you're just sort of feeling the tissue. In motion palpation, what we're doing is we're finding lines of tension within the myofascial system by having the person move into a stretch position and palpating what goes on tension first. So the steps are, put the tissue on slack, palpate, and slowly elongate. And then, after you find the line of tension, hypothesize which muscles are not moving. Okay. Put any questions in the chat. I'm going to stop my share for 1 second. I got to just reshare and add share sound. There we go. Whoa, where did we go here? Hang on, guys. Sorry, technical difficulties. There we go. All right. So next slide here. Okay, so enjoy the video. It's about 4 minutes long. This is me demoing motion palpation, and I might pause it and give you a little commentary as we go. We're not gonna think about this in terms of muscle. We're gonna think about this in terms of lines of connective tissue, lines of fascia. What I want you to do with your partner is I want you to super gently rest your hand in the posterolateral region of the neck. Now, let me demo on this side. The posterolateral region of the neck. So you're over multiple things. You're over the upper trap, you're over the levator, you're over the iliocostalis as it attaches up onto the mastoid, you're over the scalene, you may even be over the SCM. And you're going to start to move the head. So when you're assessing cervical fascia, cervical region, it's helpful to hold the crown and hold it with just a couple fingers, just gently. And you're trying to guide the person in a direction, not push the person in a direction. So they're doing the movement, you're guiding the movement. And I want you to see if you can feel underneath your fingertips where the lines of that person's tension are without thinking about what muscle you think it is. So I'm just going to move her a little bit this way, very slowly. And I highly invite you to close your eyes when you do this. Okay, so what y'all can do at home right now is you can actually do this on yourself while I teach it to you. Right, so you're not passively learning. We can make this an active learning experience. If you take your hand on the side of your neck and spread your fingers out so you're palpating as much stuff as you possibly can, and then go into the same motion that you see Kiana here going into, which is lateral flexion of the neck, and palpate and see if you can feel what goes on tension first. And you'll see me do it here. We're not gonna think about this in terms of muscle. Well, went back. I highly invite you to close your eyes when you do this. And I'm just going to tilt the head, and my hand is always going to be opposite the motion. So if her head's going that way, my hand needs to be on the side of her neck. If her head's going that way, my hand needs to be here. So my hand is always opposite the direction I'm moving the limb, in this case the neck. If I want to feel the front of the neck, I'm going to move her head back there, and so my hand is going to be out. Okay, and I can feel the moment I bring her back here, I start to feel a line of tension into this quadrant of the neck. Call it the SCM, could be the platysma. I mean, it could be anything that resides here. It could be the anterior scalene. I'm not going to worry about it. Okay, then I'm going to pull her straight back. Let's feel the front. And I'm feeling in my fingers of my left hand where I feel individual, like right there, individual lines of tension. Bring the person back out and go back in. Don't stay cranked over moving the head around. You will feel absolutely nothing but just tension, which helps you zero. You need to have no tension, and as you move the head, you're trying to feel where do I feel tension develop first. So if you're on tension the whole time, just palpating, you will learn zero. So start on slack. And I keep picking up a line right in here. We go to the back. Notice I have to bring her back out because I went too far, too fast. And that feels pretty good. Okay, so I'm starting to gather with this hand where I feel lines of tension. This is your assessment hand 1. This is called motion palpation. As opposed to static palpation, which you've learned in school, this is called motion palpation. Motion palpation is the primary form of palpation used in myofascial release. Static palpation does not really tell you much about how the tissue behaves when you put it on stretch. It only tells you how the tissue behaves when the person is not moving. So we're going to use motion palpation to pick up lines of tension. The second data is coming from this hand. As I'm moving her head, how much resistance do I feel here to the movement that I'm generating if I were to ignore this one? So where do I feel more resistance, or where does she start getting drag? Right? Drag is if I tilt her this way. See how that shoulder wants to come? Where do I start getting drag? No drag going this way. See that? But if I go straight across, boom, I get drag immediately. Did you guys see that, right? That's exactly the same thing I felt in this hand, where that line of tension was in the lateral neck, not the posterolateral, over here, for her. I want to assess this side fully, and I want you to palpate the neck, the scap, down here, up in here, just moving the head, and then I want you to switch sides and listen on the other side. This is done very, very... Okay. Here we go. All right, so that was motion palpation. The beautiful thing about motion palpation is it's giving you two pieces of information. One, the hand that is moving the limb is picking up resistance to movement and range of motion. The hand that is touching the tissue while you're putting it on stretch is picking up lines of fascial tension that can be extremely specific. This is very much like when you tune a guitar. And the first thing you do when you want to know if something's out of tune is you strum the string. And when you strum the string, it gives you a sound, a frequency that tells you how tight the guitar is. When you move tissue, if I go back this way while palpating, sideways while palpating, down here while palpating, I take it back out, I go straight down. If you move the tissue while you palpate, you'll pick up tight myofascial strings. And those are the lines of tension that you want to release. Not the whole thing, the line of tension, so that you balance the tension across the different strings, just like the guitar. All right? So if you guys got that, put gotcha in the chat so I know that you're with me. This is motion palpation balancing. Let me know if you are following this by putting gotcha in the chat or any other comment that you want or any question. Thank you, Renee. Absolutely. This is some cool stuff. I love this stuff. All right. So once you find a line of tension, how do you release it? What is the specific way to release the myofascial restriction? Okay. Well, we know we need a combination of three things. Stretch in all three planes of motion, ideally. Compression over the point of restriction, and then shear force in the direction of the fibers where you want the fibers to go. All right, so for example, let's say we picked up a line of myofascial restriction in what we would call the person's latissimus dorsi, basically the myofascial complex of the lat, something over here. How do we put that tissue on stretch properly? We ask the question, what does the latissimus dorsi do? And it actually does 5 things. It does shoulder extension, adduction, and internal rotation. It side bends the trunk towards the restriction, and because it attaches to the thoracolumbar fascia, it anteriorly tilts the pelvis. If I had more room, I could show you, but basically it's like that. It does that. Pulls the arm down, pulls the butt up and back. All right. So if I want to put the lat myofascial complex on stretch, I do all of the opposite things. I put the shoulder into flexion, abduction, and external rotation. I side bend the trunk away, and I bring the knees towards the chest to posteriorly tilt the pelvis. And that, step 1, puts that myofascial complex on stretch, dimension 1. Then I find the line of tension in that. I apply compression to the restriction and then direction. And that's how we get that super targeted input to the cells. All right, so add compression and shear. All right, so let's take a look at that in action. In order to make this work, I need to scoot him slightly away from me, just a little bit, and he's going to reach up for the sky. I'm going to turn his thumb out, and I'm going to reach his arm to the upper back corner like this. Now, I can't go very far. Okay, I think in this video, I'm actually demoing first on the pectoralis major, so you'll see the same concept on the pec. With Christian before I start to tether his pec, and that's because he actually needs this technique, so this is good. Sometimes what you're going to end up doing is placing your knee up on the table and letting them lay back on your knee. So turn back towards me. Good. So now I'm going to do my motion palpation for the pectorals in this region. So go ahead and let that arm come across your body. Let it relax. Good. Okay.
Where in his pec is he most tight? So let's find out.
Okay. So notice I'm not going to treat the whole pec. I want to tune the guitar called pectoralis major fascia. So I'm going to do motion palpation to the pectoralis major fascia to find the lines of tension in the pectoralis major that need to be released.
I'm going to take hold of the tissue. I'm going to start to move him into horizontal abduction. I can assess his range, which feels limited in this hand, and I can assess the tissue tension in this hand. Then I can move the arm up a little bit, reach back. Please let me know if you get any of that pinchy discomfort you get up here. And again, I mean, that feels tight. Normally I'd want the arm to come down to level with the body. This looks like it's a good 30 degrees in front of that. So this is good that we're doing this. And then I can start to come up here. And as I keep coming up, I start to assess the lat. So I get lat, I get pec minor, all in the same position, okay? To treat this area, let's take it between R1 and R2.
So R1 is the first point of resistance and R2 is the last point of resistance.
Right about there. And then I take hold of the pec in my hand with a pincer, and I'm going to come underneath, and this is a bend technique. So I'm going to push or pull the pectoralis major. Okay, grade the intensity from 0 to 10. 7. Okay, is that too much?
Okay, so notice he graded that as a 7. I am barely pushing on that pec. So think about like how hard you have to push when you do deep tissue work to get somebody to say the intensity is a 7. Why do you think the intensity is so high here? Why is it a 7 when I'm barely pushing with that left hand? Right? It's because the tissue's on stretch. I've taken up all of that tension in the tissue globally with my right hand, and now I'm directing compression and shear into the restriction with my left hand. But because both things are happening together, the perceived intensity of the technique is so high. That means I have to do less work as a practitioner to get the result that I want. Now, some of you might be wondering, why is he lying on his side, rotated back? And the reason is, think about the origin of pectoralis major, sternum and the ribs, and a bit of the clavicle. If I lay somebody on their back and I drop the arm back like this, the pectoralis major tightness lifts the rib cage up and the person's ribs flare up like this. So if you want to tether the pec down, if you put the person on their side and roll them back, you tense the obliques, which is the continuation of the fascial line of the pectoralis major. On my right is my obliques on the left. So when you tense the obliques by having the person roll back, it holds the rib cage down, it holds the sternum down, and now when the arm goes back like this, you tether the fascia here a lot faster. And also, when the person is laying on their back, they tend to get a pinchy thing. You probably have people complain about it. This pinchy thing on the top back of the shoulder, which is compression. So when you twist them onto their side, they don't get that because the fascia catches so much earlier. Okay?
Back off or keep it there. I can also pull towards me, or I can compress.
Okay, so I'm compressing and I'm shearing the tissue towards the
work your
origin.
way down. If I get too close to the nipple, I can
Towards
ask
the
for
rib cage.
cross table coverage here.
And then here, if you're working with a person who you need to cover the nipple, you can just have them reach the other hand.
This position lends itself best, I think, to this, to literally grabbing the corner of the pec and manipulating it from here. Latissimus dorsi. I'm going to come this way now. I can dismount my knee, roll him over so he's more balanced, go into my cradle hold on the arm, make sure it's soft, hand goes on, roll over a little more, thank you. Hand goes on, teres major, latissimus dorsi, start on slack, and start to bring the arm down towards me. In order to make this work,
I don't know why that keeps happening. Sorry, guys.
start on slack and start to bring the arm.
Okay, I don't know if you can see it, but if you look right inside my left wrist crease, how taut the fascia is right there. And I've barely gotten Christian's arm over his head. Now I'm using my palm here. You could also use a thumb, fingers, fist, whatever tool to make it as specific as possible. But in this case now he's side bent over. Normally I'd put a bolster under the rib cage as well. Knees are to chest for the posterior tilt, and he's up and overhead, and he didn't need much in order to put that tissue on stretch.
Arm down towards me. I'm counter pressuring with this hand. I feel tension building up here. I hold. And I start to slide. This is all latissimus dorsi, so I can work my way all the way down the side of the body. This one is kind of one of my favorites because it's one of those techniques where people are like, and they get off the table and they're like this, and you're like, oh, that was nice. He's got long arms, so I'm just going to give myself a little more space.
All right. So that's the general idea behind myofascial release. We understand that it's a three-dimensional technique. We know that we need to put the tissue on stretch. We need to apply compression. We need to apply direction. Okay, that leads us to the next question. And the next question is, why isn't my presentation full screen anymore? 1 second, y'all. Let's go back to that slideshow. There we go. Okay, the next question is, how long do you hold it and how hard do you push? You know what to do now, but what's the dose? It's like, here's the medicine, but what's the dose? How long and how hard? Now, to understand this, we have to understand one more concept, and this will clarify how long and how hard. If you look at the top row, don't let's confuse, look at the top row. What you're looking at on the top row is resistance. So we call it R. And so when you put something on stretch, you could do this with your own forearm while I explained it to you. At first, if you're in the slack zone, there's absolutely no tension. So that's this over here on the left-hand side. Slack, nothing. As you bend your wrist and fingers backwards, you will get to a point of first resistance where this hand, the therapist hand, just begins to feel resistance. So in my forearm, you can try this now with me. Right there, right there. It's like I take the slack out of the tissue. So here's the tissue, it's on slack. Donnell, this one's for you. Take the tissue, it's on slack. It's like right there. It's like, not that, it's like right there. R1 is the point at which you've taken the slack out of the tissue. The first point of resistance, okay? Then you get this spot where now you can keep pulling between R1 and R2, and eventually you get to R2 where it don't go anymore, and that's called the end feel. It's the end of the range of motion. And if you were to try to go any further, you are at risk for injuring the tissue. Now, this is true when you put stuff on stretch. Guess what? It's also true when you compress things. So when you compress tissue, look, R1, first point of resistance. R2, I can't go any deeper than, just doesn't sink anymore. So compression, tension, shear, R1 and R2 are all going to work. Here I'm demoing with tension because it's the easiest one to understand. Okay, what is S? What is this S? R1, S1, what's S? S is the client's sensation. So now don't pay attention to what you feel in this hand, the therapist. Pay attention to what you feel in this hand, the client. As you bend your wrist backwards, when do you first feel the tissue go on stretch? Not when do you feel it in this hand, when do you feel it in your body? That is the point at which the client says, I'm just beginning to feel a stretch. It's sensation, S1, the first point of sensation. Then you've got S1 to S2 as the stretch increases, and then S2 is the stretch tolerance. That's as much as they will allow you to go. And anything beyond that corresponds to pain, which is their sensory experience. Okay, so I want you to focus right now on the R, R1 to R2. It's taking the slack out of the tissue and stretching it all the way till you get to the end point, which matches usually that person's stretch tolerance. Just keep this in mind as we go. All right, this was a study done on viscoplasticity. Now, viscoplasticity is what the technical term for permanent lasting change in tissue is. So when you say stir the honey, temporary changes, the honey gets gooey, feels good, and then a couple hours later it stiffens back up, that's a viscoelastic change. It goes back. A viscoplastic change is when the change doesn't go back. It's permanent. That's what this study looked at. So if you look at the horizontal axis here, it's time. So 10 to the second is 100 seconds. So a 10 to the third is 1,000 seconds. So it's 10 times 10 times 10. It doesn't matter. Basically, the bottom is time, and it's in the order of minutes. The vertical axis is the degree of plasticity. In other words, the degree of change. How much change do you get in the connective tissue? And what do you notice about the slope of the curve? It's linear. The more time you put connective tissue under stretch, the more remodeling you get, and it doesn't plateau. So if you could literally work on somebody's tissue for hours and hours and hours, you would continue to get benefit, benefit, benefit. Of course, you can't do that because they would be sore as hell, and nobody has the time to do that. But in theory, the longer you hold something, the more remodeling you get. That's why myofascial techniques need to be done slowly and for long periods of time. The longer, the better. That's also why you don't just treat the whole thing. You don't have time. If you need to work on 6 muscles, that is going to take you the whole session. And you have to divide that 60 minutes by 6. Each muscle only gets 10 minutes. That's not enough. You want to take those 6 muscles and divide them over 3 sessions. So each muscle is getting 20 to 30 minutes of myofascial release. So the pec is getting its due dose of everything that it needs over a long period of time to truly get those lasting changes. So if you're trying to do myofascial release and you're noticing your changes are not sticking, the first place to look is duration. Are you doing the technique to a specific tissue long enough to allow this linear change to occur? What about intensity? How hard do you have to push? Now, if you look at this graph, on the x-axis is stress. In other words, how much force is being applied, and on the y-axis is degree of change. And what do you notice about this curve? It plateaus. In other words, more isn't better when it comes to intensity. Yes, you need enough, but you don't need more than enough. Your desired intensity is to get to what we call the maximal therapeutic dose. How hard do you have to push to get to that peak, but not any harder than that where you actually induce inflammation and tissue damage? So where is that? How do you know you're there? R2. When you get to R2 of any of these levers, whether it's compression, shear, or tension, each of those levers has an R2. And you want to stop pushing harder and harder when you get to R2. So when I put something on tension, R1, R2, I treat it at R2. When I apply compression to R2, and then I shear it, see if you can see this, then I shear the connective tissue to R2. Each one of those levers is taken exactly to the R2 point, and that will indicate the maximal therapeutic dose that doesn't go beyond that to the point where we get pain or, God forbid, tissue inflammation or tissue injury, because it peaks out. And then how long do you hold it? As long as the client can tolerate, or as long as you can tolerate, or as much time as you have. Okay, we're going to bring it all in right now. Now's your chance. If you have any additional questions, ask those in the chat right now about anything that we talked about today so far, or anything related to myofascial techniques, or pretty much anything. I could try to answer any question you have, because I enjoy talking about this stuff. So let's recap. In part 1, we talked about myofascial release as a bodywork modality designed to improve the glide and extensibility of stiff, short, adhesed, or disorganized myofascia. We learned that pushing and pulling on the skin does not influence the myofascia. That should be properly termed dermal fascial release, not myofascial release. We learned that stiffness is defined as resistance to stretch, and it's really due to the viscosity of the ground substance. Remember, it's a honey problem, and it can be treated with any technique, including techniques my 12-year-old would use. You just warm up the tissue and it feels so good and juicy. But it goes back because it's honey. Shortness is defined as abnormal tissue length due to adaptive shortening or adhesions in the fibers. And that needs to be treated by talking to the cells, and the cells remodel the tissue. And myofascial release, when done in a three-dimensional way, is the most effective way, in my opinion, to do that. We also learn that the cells do the work. Force is the language of cells. And myofascial release works best and most accurately when it's applied in 3 dimensions: tension, compression, and shear. What do you release? Well, we release the tight strings on the guitar. We want to balance the system to eliminate the symptom. How long do you hold it? As long as you or they can tolerate. And how hard do you push? Just enough to get to R2, which is where your intensity is going to plateau. So that is the version of myofascial release that I think is backed by science most. It is the one that I use in my practice, and it's the one that's most effective. So I want to wrap up real quick. For those of you that are interested in myofascial release, one of the most effective myofascial tools that I use in my clinic is actually cupping. Rather than compression, it's decompression. It pulls up, but all the other same stuff works. And I have a course I'd like to offer you guys. If you want, I have a coupon code. And we have myofascial cupping. It's a certificate course. It's online. It teaches all of these different things: blood flow techniques, desensitization, muscle spasm, stiffness reduction, all that really good stuff. It also is 3 hours long. You get 3 credits for it. Comes with a course manual, protocols, full color, diploma, and there's a bunch of bonuses in there, which you can see at the bottom of the screen. I include a marketing kit. I put a cupping list in there. You get the emblem. There's an online on-the-go app. And another course I did, I included in there as well. And if you all want this course, use the coupon code BIOTONE20 and go to cuppingcourse.com. So sorry for the shameless plug there at the end for the myofascial cupping certificate course. I'm going to leave this up if you guys want to go check that out. And I'm going to pass it back to Donnell, and we're going to scroll through the chat, and we're going to see what y'all's questions are. And I'm going to try to answer those as best as I can.
Well, hi again. I haven't seen any comments or questions come in the last minute. So in your recap slide, what's the collagen doing? What's happening with the collagen?
What's happening with the collagen is that the cells are reorganizing it. The cells are going to break down collagen that's in the wrong place, and they're going to build collagen along the lines of tension. And that is why the specificity of the position you put the arm, so it's along the line of tension, and the specificity of your pressure is so important, because the cells don't know inherently in which direction to lay down collagen. They are dependent upon your input with your hands. And that's why it's so important. So the collagen gets remodeled during myofascial release. Yeah.
Okay.
I do see a question here from Wendy. She said,
Yeah.
client with fibromyalgia needs myoindermal fascial release, but I have a client with fibromyalgia but is hypermobile. What do I do? Let me read that question again. Client with fibromyalgia needs myoindermal fascia, but let me just try to answer the second part of that, because I don't understand the first part. You can add a little depth to that, Wendy, if you want to. If you have somebody who's hypermobile and they have fibromyalgia, putting something on stretch to treat it, particularly end range stretch, is not a good idea. You can put them to R1, like take them to the first point of resistance, or take them to the point where they just barely feel it. But if they're hypermobile, fibromyalgia or no fibromyalgia, if you treat it on stretch and you make it more flexible, you're going to potentially make them unstable. And that's not necessarily a good thing. But if they have fibromyalgia, you got to be careful with overstretching their tissue, because they tend to get really sore if they overstretch the tissue because of the micro tears and the potential of inflammation. So you may want to consider first and foremost treating that person in the slack position and doing more of a gentle trigger point release or something like this to reduce the fascial pain and slowly working towards gentle stretch, but we're not going to take them all the way to R2 as we would with other folks. Okay, Michael's question was, can someone be hypermobile and the muscles are tight or not flexible? Yes, they can. Why does that happen, Michael? When somebody has joint hypermobility, sometimes what happens is the muscles around that joint become tonic. They start to contract to stabilize the hypermobile joint. So the person will feel tight all the time. I'm working with a guy right now who's in my mastermind group who is a hypermobile person. He has Ehlers-Danlos syndrome. He is wicked hypermobile, but he has tight hamstrings. How is that possible? Because his hamstrings are like holding on to his hip as hard as they can because his hip is hypermobile. And oddly enough, he always feels tight. He's not actually tight. It's just that his muscles won't let go. So what do you do? Well, first and foremost, you need to convince the system that it's okay and it's stable. And that's a little bit more beyond what I can explain right now. And the second thing that you want to think about doing is it's okay to do a little myofascial on a tight muscle if the person's hypermobile, but guaranteed that muscle is not actually short. That muscle is tonic. And tone is an active property of the nervous system. It's not a passive property of the tissue. In other words, if that person was unconscious, all that would go away and they'd have full range of motion. So you have to identify if it's tone and not shortness. Again, that's a different conversation, but tone is best dealt with inhibition techniques that turn tone off. So for example, contract relax techniques, one example of something that will reduce tone. So yes, you can have tight muscles. No, you don't treat that person the same way, and you really have to be careful. Deidre asked, is this course for PTCEUs by chance? Yes, it is. It depends on the state that you live in. If you head over to the cuppingcourse.com page, you'll see a list of states that are approved for this course. It's quite a lot of them, but it's not every single one. So check that page, scroll down to the bottom where it says under FAQs, is my state approved? Click on it, and you'll see if your state is listed, then you're good to go for physical therapy. Renee said, thanks so much. Very clear descriptions and explanations. Thanks, Renee. Wendy wrote, I have learned more in these 2 sessions than I have in taking days of other myofascial classes. Yay. Thank you, Wendy. Appreciate that feedback. Elizabeth wrote, I thank you for the advert. I've been thinking that cupping might do just like you said, decompress, so you can stretch, decompress, and shear. What does the shear happen while moving and slightly lifting the cup? Yes, it does. So dynamic cupping, when you move a cup around, you are experiencing some shear. It's actually moving decompression, but yeah, you're going to get some degree of shear. But you can also put a cup on something, say here, and then put them on stretch. So you're getting decompression, tension, and you don't use lotion. So it's dry. So you tension, decompression, dry cup, and then watch this. You take the cup and you pull it. It won't slide because it's dry. That targets the myofascia right under the cup. So that's actually how you get the most intense decompression and myofascial technique with a cup. You don't use lotion so it doesn't slide. It's intense. It's intense. I'm warning you, it's intense. Wendy, dermal fascia is to release nerve pain. Gotcha on R1. I agree, and do more gentle myo. Cool. Yeah. Dermal fascia will help with neuropathic pain for sure because it induces the gating response, and it also causes endorphins to be released because it's healthy touch. So that's definitely true. There's a second reason why you do dermal fascia release, by the way, which is scars. So if you have somebody with total knee replacement or they've had some sort of surgery, and when you do surgery, they go through every layer, obviously, till they get to the thing. Dermal fascial release is also really good for releasing scars in the dermal tissue. So that's also important. C-section scars, another example of scars that respond. Meryl's asking about a mastermind group. Meryl, if you don't live in North Carolina, you can't come to the mastermind group. But if you want to reach out to me, you can find out how to get more involved in something like that as we move forward into the future. Thank you for asking. So last chance, last call for any additional questions in the chat right now. We still got 30 people on, so I know you all are still interested in hearing me talk, I guess. So feel free to ask me anything you want about myofascia. You can ask me anything at all. I probably have some sort of decent answer to give you about it. And if not, then we'll wrap up in a minute or two.
And Jared, while they're compiling their comments and questions, thank you very much for another fabulous talk. I wanted to let people know that tomorrow you will be receiving a follow-up email with today's recording, Jared's contact information, the coupon code will be included, and a copy of the presentation will be there as well. If you do not receive it by early afternoon, please check your spam or your junk mail. And just to quickly mention upcoming EduTalks that we have coming up February 4th, we have Anita Shannon and Garrett Brown presenting on therapeutic benefits and effects of magnet therapy. Then February 11th, for our EduTalk Diabetes series, we have Nathan Leish, and it's diabetes and kidney disease updates. And on February 18th, we have Adrian Asto at the Massage Therapy Foundation presenting the role of massage therapy in supporting heart health. And these dates will be included in the follow-up tomorrow. I don't see any further questions or comments, Jared. Many thanks to you. And I do see you included the link, which will be as well in the follow-up email tomorrow. So thank you for that.
Awesome. You're welcome. Thank you, guys. Thank you all for attending. It's always special to me when I get to share what I've learned over these many years with y'all. It's a real special gift to me. So appreciate y'all.
And I want to remind you, January 7th, Jared's part 1. The new science of myofascial release is in the EduTalk archive library on biotone.com under the EduTalk tab. And if you need the handout after listening to the presentation from the part 1 part, just contact me and I will email you the follow-up to that presentation as well. Thank you so much. And many, many, many thanks to you, Jared.
Thank you.
Totally
You're welcome.
enjoyable. Thank you, everyone. Be safe.
Thank
Jared,
you.
thank you so much for your presentations, and we'll keep in touch.
Well, thanks, y'all. See you later.
Okay, take care.